Perfect. I do like to make jokes. Hopefully everybody likes some jokes. All right, so here's your classic definition of shock. Everybody can see my screen, right? Okay. Normally we base shock on your vital signs. All right, you're gonna have some low blood pressure, a high heart rate, okay, maybe some erratic respirations in there, okay, but that's not all types of shock. Okay, that's what you guys have to get in your head, is not every type of shock is going to show these same types of symptoms. Okay, so in my chat box there, okay, if you have a low blood pressure and a high pulse rate, okay, maybe some erratic respirations, what type of shock might I be in? I have a low blood pressure and a high heart rate. What am I looking at?
Decompensating.
Okay, decompensating shock, good. What else am I looking at?
Hypovolemic.
Hypovolemia, good. Anything else? Specific types of shock?
Neurogenic.
Septic shock.
Okay, I heard septic shock, good. Sepsis.
Cardiogenic.
So cardiogenic shock, the heart rate can go either which way, correct? The heart rate can start out. The heart rate could start out tachycardic, but then could go bradycardic pretty quickly because of poor cardiac output. Right, so cardiogenic shock could go both ways with the heart rate.
Okay, yeah.
Neurogenic.
But I think that's what we just said, cardiogenic shock. Okay, again, the heart rate could start out tachycardic, but might go bradycardic pretty quickly. Okay, because of low cardiac function. All right. Okay, so yeah, we're going to go over a lot of different types of shock and the vital signs that you should see with it. Okay. I'm going to call on people so that you're not screaming. Who hasn't gotten called on? I got up here, Michael. Is there only one Michael? Michael Brown in this class? There we go. Hello, Mike.
Good morning.
Good morning. So, Mike, when you're in shock, okay, hypovolemic shock, what is your skin color, temperature, and condition probably going to be?
Cool, pale, diaphoretic.
That's an easy answer. You got the easy one. Congratulations for being on my screen first. Cool, pale, diaphoretic. Love it. Okay, let's see. Oh my gosh, I don't know any of your names. Is that Svi? How do I say that? Shakhtar?
Dang it, great.
I'm sorry if I butchered that. I apologize. Okay. Give me another type of shock where you would see somebody cool, pale, diaphoretic.
Hypoglycemic shock.
Yeah, okay, so, I mean, so we don't call it hypoglycemic shock. What type of shock is your body in when your sugar drops so low?
Diabetic.
Well, it is diabetic, but what's causing that that sugar to be so low? You have too much what in your body?
Base.
I'm sorry, say it again.
Alkalosis.
No. What is too much in your body that's causing your sugar to drop? In diabetes, what can't they manage? They're what levels?
Insulin.
There you go. So we're in insulin shock. Good. Okay, so yeah, as much it is. I understand you're going hypoglycemia, but if you're going to tell me a shock, it's going to be insulin shock. Very good. Insulin shock. Awesome. All right. Who else hasn't answered? We have a Lopez on here. I don't have you on the camera.
Yeah, there's two of us.
No, yeah. My camera isn't working right now.
Is it? I have Cree on here. Is that a Cree or
No,
Chris?
it's Chris. It's Chris.
It is Chris.
Yeah, I'm doing it on my phone. That's why. Sorry. Yeah.
No problem. Can you think of any other shock that would be cool, pale, diaphoretic?
Cardiogenic.
Okay, cardiogenic shock. Good. Okay, probably very cool, pale, diaphoretic. Okay. Okay, Vinny, I see your answers in there, but remember there's 3 different types of distributive shocks. Good job. Okay, so since you said a distributive shock there, okay, give me a distributive shock where you could potentially see somebody who's cool, pale, diaphoretic. Vin.
Hypovolemia.
they-
Hypovolemic shock.
Okay, we said that one already.
All right. You got cardiogenic.
Okay, cardiogenic's not a distributive shock.
Well, no. Neurogenic.
Okay, so neurogenic shock. It is possible that half of your body can be completely normal and then the other half start changing colors depending on where the spinal injury is. Right? So yeah, so you could be completely normal pelvis up and then cool pale diaphoretic pelvis down or anywhere where we have spinal cord injury. Very good. Who else we got here? I had another Lopez on here.
Yeah,
Or
that's
another
it.
person. All right. Who's that other Lopez?
Christopher Lopez.
Oh my. All right. Can you tell me the other distributive shock? We had, there's two other ones. We said neurogenic. There's two other types of distributive shock. Can you tell me the other two? Or other one? Oh, Jennifer's the other Lopez. Okay.
Jennifer. I know cardiogenic. I mean, not cardiogenic.
No, cardiogenic is not a distributive shock.
We said neurogenic. Emic. Damn.
That's all right. We'll pass it on since Jennifer answered there. Jen, are you on, Lopez?
That was James being funny.
Oh, okay. That's James being funny. You guys are jerks to me. Casey Miller, I have you up here. That's you. I see you again. Let me see. You answered one. Elizabeth, you haven't answered one. That's funny.
You want
Can you
one
be-
or both?
I'll take one. Overachiever. I'll take one.
Anaphylactic?
James.
I was
Okay.
thinking that.
Anaphylactic shock. All right. Can you be cool, pale, diaphoretic, and anaphylactic shock?
Yes.
Yeah, yes, you can, especially if it gets very late. I just had a patient a month ago like that, almost died on me. Awesome. And then who wants to take a shot? Who knows the other distributive shock? Septic, good. Can you be cool, pale, diaphoretic in septic shock?
Yes.
Yes, you can in late septic shock, right? If you let it go too often. Very good, guys. So the skin can tell us a lot here. All right, so Ramses, right? In septic shock, if I get to somebody in early stages of septic shock, what might the skin color temperature condition be? Early septic shock.
They'd be hot to the touch.
Okay.
They'd be dry. I remember.
Do you
Hot,
think they'd be dry or they'd be moist?
Well, I think they'd be dry though. They could be moist.
Okay. All right, so probably moist first. Okay, because
Okay.
remember, what is that hotness being caused by?
Fever,
Fever. And
Fever.
how are we trying to alleviate a fever? What is our body doing?
sweating.
Sweating. Good. So you're not wrong that it could possibly go dry later on, especially if they're dehydrated. But in the beginning signs, you'll probably find hot, flushed, skin.
Okay.
Hot, flushed, diaphoretic. Good. Let's see who else we got on here. Is there anybody
I have a question.
who has a question?
On me, Harrison.
Yeah, go ahead.
So no, I just like that's kind of like something I never even like seen or thought of, like someone being like cool, because I always think that they're like hot, fever, you know. So like when the body like is like heating up or is a fever, is it like the body's fighting the infection, right? That's like kind of like the idea, or is it just something else that's
No,
causing
and Gary just put it up here. Couldn't the warmth be close to the infection? The answer is yes. The body is fighting the infection, so it's heating itself up.
Okay, all right. So
Right.
the later stages of septic shock, right?
Mhm.
Body's like cold and like that means that it's not even fighting the infection anymore, right? It's just like kind of just the body's
Yeah.
just letting it go, right? Kind of, or
You can only compensate for so long. Okay, your hypothalamus, which also controls your body temperature, that infection is going to go through the brain so quickly that once your temperature regulations of your body shut down, we call it reverse sepsis. Yeah, you start to become cold and pale, and that's how you know the sepsis is very bad, when you stop that temperature regulation.
okay. All right, yeah, that's I know. I just never seen that. Okay, all right, thank you.
That's right.
Just
So
wait,
yeah,
just a
yeah,
quick
I was just
question
gonna
about
say,
that.
who is that, Gary?
Yes.
Yeah, go ahead. I was going to ask you. Go ahead.
So the warmth, it started originally in the leg, and then eventually it would spread throughout the body, and then once it starts failing, it would start to cool down again, right?
Right,
Essentially.
and that's what I was going to ask you. Did this person have cellulitis of the leg?
He had severe osteomyelitis.
Oh, osteomyelitis. Okay,
They
even better.
they
Even
ended up
better.
amputating the leg.
Oh my God, was he a diabetic?
No, he broke his leg, didn't get it treated
Oof.
properly.
Oh, that stinks.
Yeah.
Mm-hmm. So yes, if you ever have an injury to an area or an ulcer or any type of cut, and most of us do, when you notice that the area gets reddened around it, that's the area it is heating up. Okay, heating up to try to fight any infections that are coming through just that cut or whatever caused the trauma. But now, if it's untreated, it will go into the bloodstream. It will go interstitially and it will eventually go into the bloodstream. And sepsis is when that infection untreated is in the bloodstream. Yes. Okay. James, did you get that? Why wouldn't you be hot anymore? Yeah, unfortunately, infections pass the blood-brain barrier very, very, very easily. That's why the very old and the very young are so susceptible to infection. Okay, who am I talking to? So, James, when you go into a nursing home and you have somebody with an infection, what's their mental status normally?
AMS.
AMS, right? Now let's go the opposite way, James. If you have a child, young child, with an infection, what's their mental status normally? Think about you with an infection. You think they'll be alert and yelling with a severe infection? Or are they going to be blah and lethargic? Okay. Young children, when they have an infection or they have a severe fever, they don't want to move. That's actually how I know my son's not feeling well. He kind of just sits there with a gaze. Okay. They become very lethargic, and then children, we become unconscious. Oh, I'm sorry.
James, even in the early stages of kids being sick, they're not really like active and yelling. They're acting sick.
Yeah. Yeah, they're just acting differently. It's hard to tell mental status on children. That's why we actually just have to look at them and see their appearance. You'll get a pediatric lecture too here at Duncan Pass. That's funny. So, but yeah, the very old and the very young do not take to infection very well. Okay. So good job. All right, next, skin, color, temperature, condition. We're going back to my beginning here. So Alexis, give me somebody who will have hot, dry, and flushed skin. Hot, dry and red. Hot, dry, flushed. What do we got?
We have hyperglycemic.
Okay, good. Hyperglycemia. So their skin may be moist or may be dry, depending on their hydration status. Very good. Let's see, Brendan. Hot, dry, flushed.
Like a heat emergency?
Like a heat emergency. Like what?
A heat stroke, heat exhaustion?
Okay, good. So obviously heat stroke will get you dry, but heat exhaustion, will you have moist skin or hopefully have moist skin?
That's the point. Yeah, when you get the stroke, you lose it.
Very good. So heat exhaustion, you should have hot and moist skin. When you get to heat stroke, okay, you should have hot, dry skin. Vin, as far as late anaphylaxis, you're going to be cool, pale, diaphoretic. Okay, I understand where the reddening might be coming from, like a rash or hives, but your body, okay, your body is giving out, okay, with bronchoconstriction and vasodilation. So in late anaphylaxis, you will probably be cool, pale, diaphoretic. Maybe early anaphylaxis, you might see the redness. So let's flip that one around. Very good. Anybody know the, yep, early sepsis, right? Like we said, early sepsis, okay? You'll be hot, flushed, and diaphoretic, okay? You might tend to dry out depending on your hydration status. Good. There's another one out there, okay? Hey, it's not a shock, but if your body is hot, flushed, and diaphoretic, what else could be going on inside your body? And I'll give you a hint. Your blood pressure is probably through the roof and your heart rate is really low.
DKA, dehydration.
Not DKA. We already said that.
ICP.
ICP, good. If you have somebody who's usually hot, flushed, diaphoretic, now you might see altered mental status, snoring, respirations. Okay, take their vital signs, you'll probably get increasing ICP. Good. Very good. That's Cushing's. So the whole point of everything I just said to you guys is when you walk into a room and you see somebody, if you see somebody who's cool, pale, diaphoretic, you're probably not thinking DKA. All right, you're probably not thinking, increased ICP. Okay, you're probably thinking some type of shock. Maybe they're having an MI, cool, pale, diaphoretic, right? The skin can tell you so much about somebody before you get their vital signs. Right, but very, very good discussion. I'll say I love to be in person because the discussion goes back and forth all the time here. Oh, and my computer froze. Bad computer. Hey, I know your exams normally ask for the difference between aerobic and anaerobic metabolism. You guys are going to have this constantly for the rest of your life on all your exams. Okay, is there anybody who doesn't know the difference between aerobic and anaerobic metabolism? Please say your piece. Okay, aerobic uses oxygen, anaerobic doesn't. Who could tell me the byproduct of anaerobic metabolism? What is the byproducts of anaerobic metabolism?
Lactic acid.
Good,
ATP.
Yeah, no, ATP is the production. That's our energy. Good. Lactic and pyruvic acid. Very good. Lactic and pyruvic acid. Good job, guys. All right, if you don't know any of these definitions, I used to pound this. Okay, I used to pound this into my students' heads here. All right, who could tell me the formula for cardiac output? Come on, first one in the chat box. Let's go.
Heart rate
Formula
times
for
stroke
cardiac
volume.
output. I don't want to hear it. I want to see it. Type fast. Come on. There we go. Thank you. Stroke volume times heart rate equals cardiac output. Okay. What's the formula for blood pressure? Come on, formula for blood pressure. If stroke volume times heart rate equals cardiac output, what times what equals your blood pressure? Everyone's like, oh God, I got to go back to cardiology lecture.
Is that mapped to something?
Nope, a map is due with ICP. Oh no, nobody? No, Miss Presidente, do you remember? Uh-oh. All right, we got to know this. I'll put it in the chat box. Okay, cardiac output times peripheral, or sometimes you might see systemic vascular resistance. So the P means peripheral vascular resistance. The S means systemic vascular resistance. It's what your heart is pumping against when it goes through your aorta. So cardiac output times peripheral or systemic vascular resistance equals blood pressure. Okay, so if if your heart is pumping out through your left ventricle, okay, and your aorta is extremely constricted, you're going to have an excessive, okay, systemic vascular resistance. This is where we get our high blood pressure. If your aorta is dilated, okay, to the point, okay, that it can't fill anymore, you're going to get a low blood pressure. So cardiac output times PVR or SVR equals your blood pressure. All right, and then the words of death back from cardiology: inotropy, chronotropy, dronotropy. Okay, inotrope is the strength of your contraction. Chrono, like a watch, the rate of your contraction. That's right. And what's the dronotrope? It's not written here. Who knows what a dronotrope is?
Conduction.
Very good. Your velocity. Good. Conduction. Good. Velocity. Okay, and preload, the amount of venous blood returning to the heart. Good. Good, good, good. A lot of cardiac lectures here. All right, we got that volume. Good, good, good. Okay, here's your map one. Okay, your map is your cardiac output. Okay, I mean, cardiac output times SVR equals your blood pressure. Okay, the map is what's going to be your mean of your blood pressure. All right, so why is cardiology so important when we go back to shock? And you're going to have a lot of questions regarding, okay, so let's do something like heart failure, okay, cardiogenic shock. If you don't know which way the blood flows and what's going on with the blood flow, you're not going to understand, okay, the signs and symptoms of these shocks. And it is. The heart is involved in all types of shocks. That's very much correct. Okay, so you're in left-sided heart failure. What am I going to see if you are primarily in left-sided heart failure? Okay, sign and symptom of left-sided heart failure. What do we got?
Fluid in the lungs, pulmonary
Good,
edema.
pulmonary edema. Perfect. Okay, and we could treat that. Very good. Okay, signs and symptoms of right-sided heart failure.
Pedal edema.
Pedal edema, good. Distal edema, JVD, good. Ascites, good. What other type of edema? Somebody said distal edema. So except for pedal edema, where else can you find edema?
And in the
Kind of depends on their position. You could find it in the back.
Okay, so
Kind of
okay, good. So yep,
like
sacral.
dependent lividity.
Yep, sacral edema. Very good. You could find it in their sacrum. Mm-hmm. Good. We got it in our legs. We got it in our neck. We have ascites. One more spot. What else could become enlarged? What else gets engorged by venous return that doesn't pump through the heart? Give me a hint. It's the upper right quadrant.
The liver?
The liver. Good. Hepatomegaly. Yep. Somebody with severe right-sided heart failure, okay, if you're ever taught by a doctor to press down here, okay, they might have hepatomegaly. Good. Enlarged liver. Very good. So good. So you guys know the signs and symptoms of heart failure. Okay. So cardiogenic shock. Okay, low blood pressure. In late stages, probably low pulse. Okay, probably tachypnea, right? Breathing really fast. So what's another sign that I'm looking for in cardiogenic shock that doesn't happen in other types of shock? And you said it. What else is going to happen in the lungs in cardiogenic shock?
Fluid backup.
That's right. You're going to get pulmonary edema. So if you're, again, so now you use your vital signs and you use your eyes and you're looking at somebody and you're like, wow, you're cool, pale, diaphoretic. Your blood pressure's low. Your heart rate's low. Let me listen to those lung sounds. If you start to get rails, even just in the bases, you're in cardiogenic shock. You may not always hear the rails, but they're going to be coming. So tell me who's next on my list here. I got you all in order here. You answered, you answered, you answered. Usually I have an app for this. Who's not on my screen? Tom, you're not on my screen. Can you hear me?
Yeah, I can hear you.
Awesome. So Tom, how do you treat cardiogenic shock? Someone's got fluid in their lungs, and their blood pressure's low and their heart rate's low.
Usually we might want to give a fluid challenge possibly, but if he's
Okay,
so it's usually a 250.
good.
What else might we do?
Yep, you tell me. What else might you do for somebody in cardiogenic shock?
If possible, we could use if there's fluid in the lungs, we could do CPAP. If
Okay, so now here's the argument. Can you use CPAP with somebody with a low blood pressure?
no, because actually that would probably make it go even lower.
Right, you'll drop cardiac output. Good. Gary, I'll get back to you on that one. Okay, so no CPAP. Once your blood, honestly, I don't like using, I know the protocol says, I think it says above 100 now, they keep changing it. Anytime your blood pressure is teetering around 100, I'm very wary about the CPAP. Okay. All right, so I got a couple answers here. So pressors, Elizabeth, what type of pressors are we using?
Maybe norepi.
Maybe norepi. Is that a question or an answer?
Well, so on Long Island, norepi, because it's the pressor that we have.
It's the pressor that you have. Good, good. You know the dosage?
Norepi 4 milligrams in a 100 bag with 2 to 20 micrograms a minute, titrated to.
Yeah, I was just gonna say, not the concentration. What's the dosage?
2 to 20 micrograms a minute. I'm going through it in my head. 2 to 20 micrograms a
Gotcha.
minute.
Okay, good.
Titrated to a blood pressure of, probably, not usually, whatever, you're titrating to. Although, can I ask, because somebody said you're really titrating to a map, are you really, so what are you really looking for when you're titrating it?
I'm titrating, some people do titrate to a map if you do have a map available on your monitor. Okay, I'm titrating for the fact that my patient looks better.
Yeah.
Remember, yeah.
Transporting probably long enough to do too much of that. So yes,
Well, that's true. Anybody's blood pressure that goes above 90 or even at 100, I'm going to, titrate back down. If I can maintain somebody's blood pressure, around above 90 or around 100, that's where I'm going for. Good. Let's see. Keep warm and elevate the legs. God, I'm going to say your name wrong again. Is it, you said Koray?
Korai.
Korai, I'm sorry, Korai. Korai, why can't we elevate the legs?
What did like for fear the increase in cranial pressure, or like the fluid?
Yeah, not only intracranial pressure, but anybody having chest pain. Do you think they're even going to be comfortable lying down?
Probably not.
No, and especially if you have fluid in your lungs, are you going to be comfortable lying down?
No.
Yeah, so I understand the blood pressure is low, but this is where people don't understand. They get EMTs are like, oh my God, you're in shock, you're in shock, you're in shock. We have to lie you in Trendelenburg. That Trendelenburg only works for a hypovolemic shock to try to get fluid back to the heart. It doesn't work in cardiogenic. You could drown somebody. It doesn't work in anaphylaxis. What's raising your leg in anaphylaxis going to do to somebody?
Nothing.
Okay, so yeah, so be careful elevating legs. And for James, the answer is we do still elevate the legs, but it has to be warranted. So a hypovolemic shock, go ahead, lie somebody down, put their legs up. If somebody had a syncopal episode because they dropped their blood pressure, sure, put them down, put their legs up a little bit. Not a problem. All right, but yeah, so cardiogenic shock, somebody is going to want to be definitely sitting up. Okay. I saw somebody else wrote, I got that. James, you said epinephrine. You guys still have push epinephrine in your protocol, I think, in the city, right?
Yes, push those up in standing order.
You got push dose epi, blah. So fine, push dose epi, I'll take it. I don't know, does anybody have dopamine in their protocols anymore?
City still has it.
City still has it, then I'll accept dopamine. Okay. Svi, you said Lasix. Come on and talk to me about Lasix.
Oh, I was thinking Lasix, if you can't use CPAP because the blood pressure is too low, maybe Lasix to help get that fluid out or maybe help with perfusion and so on.
Okay, so the problem, first of all, let me tell you about Lasix. Lasix should be taken out of everybody's protocol. Okay, Lasix used to be a standing order pushed by every medic and CC that is out there thinking it was a life-saving drug. It is not. Okay, even getting a medical control order for Lasix for like a pulmonary edema is very rare. You have to be on Lasix and missing your dosages in order to get that, or they go to the hospital and they have to actually confirm pulmonary edema. But Svi, tell me, so you want to get rid of the water in their lungs, but now is the water in their lungs being caused by like a retention, like an overabundance, like your kidneys aren't working, or is it being caused by your heart failing?
It's by the heart failing. So I was just thinking, like, you don't want to put fluid, you don't want to put Lasix, use Lasix when that fluid is from sepsis or infection, right? That wouldn't be good. But in this scenario where it's from the heart, that's like ruling out the sepsis. I was thinking there I wouldn't use it. That was my logic.
Okay. Yeah, we wouldn't want to use it. It's actually funny because having fluid in the lungs, you would think we don't want to put more fluid in the lungs, but the answer is we do, because our vasculature is so depleted of fluid that we need fluid in there in order for our pressors to work. So by giving a 250 to 500 bolus isn't flooding our system, but allowing our pipes to fill up with fluid to give us pressors, something to pump, and hopefully giving our heart to pump, and then the heart will pump that fluid out. So that's the premise of it. If we give Lasix, we're going to tend to dehydrate and, remember Lasix is non-potassium sparing, so we're going to ruin electrolytes, we're going to take too much fluid out, and it's not serving the purpose of the underlying reason why we're going into shock. We are going into shock because of pump failure. We need to fix the pump. And in order to fix the pump, we need pressors, okay, and fluid.
So, Maria, at that point, would you use normal saline or would you use LR?
No. We don't want to replace any type of electrolytes. This is not an electrolyte imbalance. So yeah, so normal saline would do just fine in this. Yep. So that's basically it. Normal saline and pressors. Okay, because even these pressors should, even if you have a low heart rate, these pressures should be taking care of the low heart rate too. Cool. We have ejection fraction here. Somebody said that they had an ejection fraction of 5%. Good luck measuring that. A cardiologist once told me that they couldn't measure under 10%.
The cardiologist came into the ER for the consult, and they spent a good couple minutes trying to figure it out. They were getting somewhere around 5% each time.
Yeah. Honestly, if you're going that low, you need a balloon pump and a heart transplant. So, yeah. An ejection fraction that low means you're going to be on the transplant list.
It was just an issue with his valves. They were barely open. Like, it was the valves that were the issue. Everything else was working fine.
Oh, that's good. Well, that's good for them. They just have to go up and get new valves.
Funny enough, he came in.
For that person.
He came into the ER for a GI bleed, completely unrelated.
Oof. Oh my goodness. Well, we always say sometimes, breaking a bone can lead to you finding out a diagnosis of cancer. So, always go to the hospital.
My daughter had a fall and some stitches in her head, and we found her brain tumor that way. So, you know.
You know what? Sometimes by the grace of whoever you believe in, that stuff does happen.
And by the way, finding it early like that was life-saving, so for sure.
For definitely sure. That's why I tell people, don't ignore signs and symptoms. Go to the hospital. Okay. But your EF, your ejection fraction, okay, the percentage of volume leaving the heart to what comes back at the end of diastole, it should be 50 to 70. So for somebody to have 5 or 10%, okay, heart failure starts when you're below, usually, I talked to a cardiologist, they said around 45%, we should start to worry, but anything under 40%, you're going to be in heart failure. All right. Come on, computer, work with me. All right, we have vascular, we just did this. Come on, let's get into. Okay. So who can tell me where baroreceptors are located? Well, that's a big one. Where are baroreceptors located?
Aren't they located in the peripheries?
Peripheries meaning?
So your extremities, your arms and legs.
Not your baroreceptors.
Aren't they in the kidney?
Yes, they're in the carotid sinus. Yep, they're in the carotid sinus and the aortic arch. Okay. And what do? Baro, what does baro have to deal with?
The lungs, right?
Measure pressure.
No, it's the
Measure
pressure of the
pressure.
environment and the body, right?
Very good. Very, very good. Good job, guys. Okay, so let's go to chemoreceptors. So now, how about this one? Where are your chemoreceptors located?
Doula, I'm not sure.
I love that. Keep going.
I was right.
You were right. Finish
medulla,
it.
yeah, medulla oblongata.
The medulla oblongata. Very good. In other parts of your brain. Good. And what do the chemoreceptors do?
They regulate the CO2. No, they I don't know. Oh.
I wish you would finish. You need a little more confidence.
Okay. Let me try. They monitor the CO2 levels in the blood, and they regulate respiration.
Yeah, they regulate your pH, right? So you have too much CO2 in the blood. Your body's going to tell you to breathe faster. Okay, you have too little. They're going to tell you to hold your breath. Good. Be more confident. You got this. You got this. Good job. All right. So this is why it's so important, okay, for us to have, good, brain functioning. All right. Because if anything goes off in any part of our body, it can affect so much other stuff. Like we don't realize, that our pH in our bloodstream could change at an instant, or why we start breathing faster, or why, we start breathing slower. Our brain's telling us something. Okay. Adrenal glands, somebody, remember I said adrenal for adrenaline. Okay. Your adrenal glands release, epinephrine and norepi, but that's on the adrenal medulla. Okay. You have two parts. You have adrenal medulla and an adrenal cortex. Anybody know what's released from the adrenal cortex?
Cortisol.
There you go. There you go. Good job, guys. Very, very good. Okay. Let's see. Let's go back over here. So, Mr. Lopez, Chris Lopez here. What is this renin, angiotensin, aldosterone thing? What is this? Renin, angiotensin.
I don't know.
You're not sure? Okay.
Yeah.
That's all right. Does anybody know what renin, angiotensin is?
It's something to do with protein.
Kidney's way of regulating the blood pressure. As blood pressure goes down, the kidneys release renin, which then gets converted to angiotensin to help increase blood pressure.
Very good. It goes to angiotensin 1 into angiotensin 2. Very good. In response to low blood pressure, yep, it will constrict your vessels. Very, very good. So it's not just your brain that kicks in or your respiratory kicks in or your heart kicks in. Your kidneys will also kick in response to low blood pressure. Very, very good. Okay. And the aldosterone, okay, that's in the adrenal cortex also. All right, that is essential for sodium conservation. Okay, so your aldosterone will kick in, try to keep sodium in your body. Good job. Okay, vasopressin. Anybody know the other name for vasopressin? Going back to pharmacology, vasopressin.
Antidiuretic hormone.
Very good. Antidiuretic hormone. So here again, here's your pituitary glands coming into play. Okay, they will release vasopressin, trying to, keep your blood pressure increased, keep all that fluid in. Does anybody know what deactivates vasopressin? Most of us do it every night after paramedic class. I probably do. What is that?
Alcohol.
Alcohol, good, yeah. If you ever wonder why you drink alcohol and then you break the seal and you can't stop peeing all night long, alcohol inhibits the production of vasopressin. So don't break the seal. Once you break the seal, there goes all your vasopressin. It's pretty funny. Good job, guys. Very good. All right. Okay, so we spoke about a VQ mismatch. Okay, ventilation perfusion mismatch. Okay, what type of shock might you find a ventilation perfusion mismatch? What type of shock might you find a ventilation perfusion mismatch?
Obstructive.
I didn't hear.
Obstructive.
Obstructive, very good. Can you give me an example of an obstructive shock?
And anaphylactic shock.
Anaphylactic is under distributive.
Oh, okay.
Think of something that obstructs.
Pulmonary
Cardiogenic.
No, cardiogenic's on its own. Okay, somebody said a pulmonary embolism. That's correct. What else? What else could obstruct your breathing or the movement of blood? I'll give you a hint. If you're good, pneumothorax. Good. Somebody said cardiac tamponade. Very good. I was going to say, think of your H's and T's. Good. Good. Pulmonary embolism. Okay. Cardiac tamponade. Tension pneumothorax. Good. These are types of obstructions. Some of them we can fix. Wait, what did you say? Jonathan, I didn't hear what you said.
Oh no, that's what I said. I said pneumothorax.
Oh, you said pneumo. Okay, good.
Yeah.
Now, again, some of them we can fix. Can we fix a pneumo? Hopefully. Yes, we can. Anybody know how we can't fix a cardiac tamponade, but anybody know what we could do?
Rapid transport to an
Yeah,
OR.
I love rapid transport. What else we got for us? What else can we do for a cardiac tamponade? The only other thing medics do really well.
Sleep.
Give fluids.
Give fluids, right.
Fluid.
I know, again, it sounds counterproductive, but remember, in a cardiac tamponade, okay, the fluid is going probably into the pericardial sac and it's not staying within the heart. So us giving it fluid, okay, we need something to pump. Okay, so again, just a 250 bolus, maybe if you're, far from a hospital, up to 500, but, just keep that fluid going. Nothing ridiculous, okay, but just keep it going. Good. Very good. That's your obstructive shocks. Excellent job, guys. All right, we know how to treat hypovolemia. That's easy. We know how to treat hypotension. That's easy. Treating hypoxia. That's easy. Okay. Let's see. All right, so we're going to get into some different types of shocks here. Let's see. So we did hypovolemia. Okay. Can you give pressors in hypovolemic shock?
I learned that by killing my simulated patient the other day.
I wouldn't.
No.
Who is your instructor?
I think I was with Barry.
Okay, so lovely, Barry. So you have to remember, a lot of people are old school. So what is your first treatment to somebody who's in hypovolemic shock?
Fluid challenge.
Fluid challenge, right. How many liters are we allowed to give?
Up to 2.
Okay, is that the new one, up to 2? Because they change protocols on me all the time.
Yeah,
Up to
up
2?
to 2,
Good.
max of 3 with medical control.
With medical control. All right, awesome. Okay, so now let's say, you know, you're working in Far Rockaway and your ambulance breaks down and you can't get to a hospital until another unit comes to help you out. And this fluid, now you've maxed out on your 3 liters. Okay. Is it probable that we could try, okay, pressors in hypovolemic shock?
My logic was yes.
The logic is yes. It's not something that we commonly do. And mind you, if you would see a test question, which of the following forms of shock is least warranted for pressors, the answer would be hypovolemic. All right. But if you're in a state where you can't get to a hospital and your transport time is through the roof and you've exhausted everything else, you can always call for a discretionary, you know, to start a pressor. Okay. But again, in simulation, you have to exhaust everything that you could possibly do first. Right? Because the pressors aren't going to help with the burns or the diarrhea, the vomiting, or the blood loss. Right? It literally is a last ditch effort to get somebody to the hospital alive. All right. So Barry wasn't wrong in probably tanking you, but the whole thing is, if you did it first, that's a problem. We don't do it first. Discretionary. All right, we spoke about cardiogenic shock. You guys did very well on that. Okay, we just did obstructive shock. Very good. I don't know if there's any other questions on that one. All right, so we have so now, let me get somebody on here who hasn't answered in a while. All right, unless somebody wants to volunteer. All right. I'm going to pronounce your name wrong, unfortunately. Gunsham, I'm sorry. How do you say your name?
Gonsham.
Gonsham, I'm sorry.
It's okay.
We know that anaphylaxis, sepsis, and neurogenic are the 3 types of distributive shocks. What is so distinctive about distributive shock versus all the other shocks?
It could be fatal, like right away.
Well, so could cardiogenic shock. What's the difference between distributive shock and every other shock?
The signs and symptoms.
Okay. You could have the same signs and symptoms, but all right, internally, what is different?
Blockage.
Okay, that's all right. Does anybody know internally what's going on in distributed shock versus any other type of shock?
It's fluid displacement.
Fluid.
How? What's going on?
There's a block.
It's losing it between the spaces.
How? What's going on with your vessels?
They're collapsing or expanding, kind of like the permeability is like collapsing.
No. The permeability is expanding. We have massive vasodilation. Where in the other shocks, what do you have?
Vasoconstriction.
Vasoconstriction, right. So in neurogenic, okay, sepsis and anaphylaxis, you have a dilation of your blood vessels. Then not so much lack of air exchange at the cellular level. That's you're going. That's not what distributive shock is all about. Distributive shock, okay, is all about the impaired distribution of blood flow. Okay, and that's because of massive vasodilation.
Got
Right. Okay, so let's go to each individual one. Okay, how do let's see, Harrison, how do you fix anaphylactic shock?
Epi, but you constrict the vessels, epi.
Okay, but now we're constricting our venous and arterial return, but why is epi also helping? Not only for the blood pressure, what is epi also doing?
It dilates the bronchial.
Very good. All right, so we use epi to dilate the bronchioles. Awesome. Who's next?
Alpha. Yeah.
Good. Elizabeth, how else do we treat? How else do we treat anaphylaxis besides epi?
You would do the diphenhydramine or the antihistamine, stop that vasopermeability that you get.
Okay. Okay, good. So in early stages of an allergic reaction, we're going to give an antihistamine. Okay, so good. So we're going to give some Benadryl. Excellent. Let's see who else is on my list here. Jonathan, what else are we going to do?
So we give epi, we give also if we notice or hear later on any wheezing, we can always also give albuterol.
Okay, good. You can give albuterol. Some places allot you to give a combi treatment depending on your protocols. Good. And then dexamethasone. Good. I saw that, Steve. Good.
Maria, fluids also to sort of fill that vasculature that's dilating.
So it's funny enough, it's not in our protocol, but anytime I start an IV on somebody who is showing any time of symptom of shock, remember, you don't have to give fluid boluses. You could just keep vein open just to run it, okay? Because, that epinephrine, that you're giving, okay, the epinephrine should help with it too. But of course, that's what I had to do on my last patient. My last patient was in such bad anaphylaxis that his blood pressure was 60/30 and his heart rate was 40. And the epi wasn't working fast enough. I actually had to give him a liter of fluid and I had to give him atropine. So I kind of went off protocol, but when you have somebody in such a state and your initial treatments aren't working, you may have to do something else. Okay, this guy was an extreme case. I even spoke to Nicole about it. I was like, this is an extreme case. But sure, get those fluids running.
It actually is in protocol now, 500 milliliters of fluid for anaphylaxis.
Okay, so yours changed and see mine didn't. Like I said, I've got city protocols, NASA protocols, and Suffolk protocols in my head. So honestly, I put
this is NASA pro. I mean, that's whatever that I just opened NASA protocols. Fluid.
But yeah, give fluid. Fluid is not a problem, but just remember, I'm sure a lot of your instructors are like, why is everybody giving fluid? You don't have to jack somebody with fluid. Okay, fluid, you can always keep vein open or just have it running just in case other measures, don't suffice. Okay, that's not a problem. If you're going to start an IV, attach a 500 to 1,000 bag to it. Not a problem. Keep it going. Okay, because now we also know, and we did, how do you treat cardiogenic shock? We need fluid impressors. And then how do we treat septic shock? What's our only real treatment for septic shock?
Fluids and pressors if the blood pressure dips too.
Right, fluids to maintain a blood pressure. Okay, but again, just like you see this, all these distributive shocks initially will start out as a warm shock. Anaphylaxis starts out warm, sepsis starts out warm to hot. Okay, neurogenic starts out warm, and then all of a sudden, if left untreated, you will go into this almost irreversible, this cool pale diaphoretic shock. Cool.
I read something that says that in septic shock, you can actually lose body temperature by up to like a whole 10 degrees, like of core body temperature. Is that common or very rare?
No, it's common. Think about it. When you have a fever, don't you shiver?
Yeah, but isn't that just a sign and like a symptom, not necessarily like an actual acute finding of the body? Like the core body temperature doesn't usually drop with a fever, though.
It could drop a degree or two. If you're a healthy person fighting a fever and your core body temperature is 98.6 degrees, okay, your core body temperature is probably going to go up, 99, 100, stuff like that. You're going to shiver to create heat. That heat is also going to, help fight infection. But now you're not a healthy person, you're very old or you're very young. And if the body's only going to compensate to those fever levels for so long before its regulations are going to drop. So it is common when it starts to get to a late sepsis that when you feel somebody, they're freezing cold. Oh yeah, that's their body temperature dropping. You got to keep them warm. Right? So in beginning stages of sepsis, when you can fry an egg on somebody, what I do is I usually just put like a sheet over them. I mean, they still have to release heat, but I want to make, keep them presentable. But in late stages, especially children have to maintain body heat in order to maintain, mental capabilities. You got to keep them warm if they're in that reverse stage.
Gotcha. Thank you very much.
No problem. And yeah, Vinny, you're right. The body will start to shunt. Okay, but that's in late sepsis. If you get to sepsis early enough, we should be compensating with that body temperature. Very good. So let's see if we get through this. Let's see if we can get through this and take a break. Okay, so the neurogenic shock. All right, unopposed parasympathetic response. Okay, what does, let's see. We got Tom on here. Tom, I got you on my screen. Okay. Parasympathetic response. If your body is going through a parasympathetic response, what does that mean? What's going on in your body?
Well, parasympathetic is like rest and digest for the most part.
Correct.
So,
very good.
Well, that's what I think of. So you probably want to work your digestive system and lower your blood pressure, usually.
Oh, okay. So it's gonna also, so now do you have, if it's unopposed, does that mean that your sympathetic nervous system is kicking in to help with any type of constriction?
No.
No, it's not.
Because it's unopposed. Yeah.
Right, because of some type of usually injury or disruption of the spinal cord.
Yeah.
Okay. So yeah. So this is where we get our massive like vasodilation from. Okay. Whatever your gastric movement, salivation, lacrimation, emesis, the whole sludgeum. Okay. Unfortunately, there is no sympathetic nervous system to help out what's going on here. Okay, so depending on where the injury occurs, anything below that injury is where you're going to see these signs and symptoms. Cool. Very cool. All right. And we did anaphylactic. That's easy. Okay. Sepsis, guys, do not take sepsis lightly. Treat. Call in a note. A lot of nurses should have a sepsis protocol already. If you're in triage and they're keeping you in triage for 20, 30 minutes with a septic patient, they're not doing their job. All right. Sepsis can go very downhill very quickly. That's why we get those lactate levels in the hospital. When you start having elevated lactate levels, you might not be able to reverse them. Not how much antibiotics you give or how much fluid you give. Okay, so identifying sepsis and treating sepsis early is really, really, really important. Yeah, a lot of people let UTIs go, or they find a little cellulitis on them. If you have an injury or you think you might have a UTI or respiratory infection that's not going away in a couple of days, you need to seek medical help. All right, so we did speak about this a little bit. Okay, compensated shock. All right, increased catecholamines. What are our 3 catecholamines, Casey? What are the 3 catecholamines that are released in our body? She's like, oh, bro. I'll give you a hint. 2 of them are from your adrenal medulla.
Epinephrine and norepinephrine.
Thank you, Casey. Your voice changed really nicely. I love it. It's awesome. Good. What's the other one?
Is it
The other-
acetylcholine?
No, acetylcholine actually drops. That's released in a vasovagal response to drop your blood pressure and your pulse. What's
Okay.
the other pressor we use? It's in certain protocols. Dopamine. Good. I heard somebody say it lightly. So 3 catecholamines. Okay,
Dopamine,
dopamine, norepi, and epi are released in order to maintain blood pressure. Okay, that's our first thing that goes. Okay, you know, your kidneys will kick in, your respiratory cycle kicks in, but these catecholamines are vital to our survival. All right, and we know if you can't maintain a systemic blood pressure anymore, it's going to drop. That's very easy. Let's see. Okay, so as we look at it as decompensated shock, right? If somebody has a blood pressure below 90, they are decompensating. So when you do your scenarios, guys, anybody with a blood pressure below 90 is decompensating. They'll probably altered mental status. They will have skin color, temperature, and condition changes. You should start using your unstable protocols, okay, once you hear that that blood pressure is below 90. Once somebody is altered mental status, okay, they are starting to decompensate. Okay, I understand pulse ox levels, but pulse ox levels are a late finding. Okay, anybody know what you should be put on if you have it available instead of a pulse ox?
No.
Capno, right.
Pornography.
Capno is going to tell you right away. Good, good, good.
Especially with kids and especially with asthma kids, because boy, I could tell you my daughter's been intubated 5 times and I've never seen her pulse ox drop below 98.
Correct. And that's how somebody like Joan, I don't know if anybody remembers who Joan Rivers was. Okay, Joan Rivers, okay, famous comedian, loved her to death. Yeah, lots of plastic surgery. She always joked about a plastic surgery. Funny enough, she went in, I think, just to have a regular throat procedure done, and they only had her on a pulse ox. And she stopped breathing, and nobody noticed it in the, in the office. If she would have had a capno on, they would have noticed that she stopped breathing. But yeah, nobody was paying attention to her, and she died of hypoxia. Because it could take more than 6 minutes for a pulse ox to drop because you have 6 minutes of oxygen circulating through your body. So always monitor your patient, and if you can, put them on capno right away. That rising capnography, okay, will tell you if somebody is acidotic. God forbid it's that low. I mean, Elizabeth says her daughter's been intubated numerous times. Okay, that could be a massively low capnography too. All right, using things like CPAP on somebody if they're still alert and oriented with a good blood pressure. Okay, but yep, love capnography. Wish it was more prevalent. Okay, and then irreversible shock. I mean, this is just late stages. You're not going to get them back. Okay, probably not going to get them back. Multi-organ system failure. All right, your cells are so acidotic that it doesn't matter how much bicarb or how much fluid or calcium or anything you pump into somebody, they're just not coming back. All right, your body has been in a state of anaerobic respiration for way too long. Ah, James, you remember the Fashion Police. Yeah, I love that. Fashion Police. Okay, and yep. All right, so I said the very old and the very young. Okay, remember, children compensate for a long time, and then once they decompensate, you're not getting them back. So you might want to note that. Children compensate for a very long time, but then they crash. Okay, where adults, especially older adults, we can compensate, but we actually decompensate for a longer period of time. Okay, adults will go into VTAC and VFib. Children very rarely go into VTAC or VFib. All right, so adults decompensate for longer, children compensate longer. Then, of course, if you have any other pre-existing diseases, whether it's heart disease, diabetes, pulmonary issues, kidney issues, obviously your state of shock is going to be faster than anybody else's. Okay, we take care of hemorrhaging, blah, blah, blah. All right, this is, okay, I mean, SpO2 of 94 or better, fine. Oxygen by nasal cannula is a wonderful thing. Okay, it is in new protocols. We don't have to blast somebody out with oxygen. It's actually been known that oxygen can actually hurt certain things like a heart attack. Okay, so a nasal cannula to continue at 94% or above is amazing. Let's see. All right. We spoke about lactated ringers and normal saline beforehand. Honestly, normal saline works very well for a lot of our shocks. If you have somebody in the so-called burn shock, if you have a burn victim, I would try to get electrolytes into them. So if you do have lactated ringers, okay, lactated ringers are great for burn shock. All right,
Okay.
otherwise normal saline is fine. What's up?
I'm sorry, Maria. Sorry to cut you off. I just have a quick question. So
Yeah,
like
go
in
ahead.
like in shock, if somebody has SpO2 of like 97, 98, right? But they're pale, cool, diaphoretic, and you're treating them with fluids and, you know, pressors and everything. Can we give the oxygen though, just to like kind of, all right, cool. Just
Yeah, of
wanted
course.
to,
Because remember, we don't know how long they've been compensating like that for. And again, you know, oxygen levels will always remain high until they don't. So at least for 6 minutes. So giving somebody a nasal cannula just at 2 liters just to maintain perfusion is never a problem.
okay.
Yeah.
But nothing
That's all.
extreme like a counter breather or nothing like that.
Yeah, you don't have to have anything extreme. No. We tried to get rid of that extreme as long as they're not having difficulty breathing. Okay, we were, you know, EMTs and medics, we were told to always use oxygen. Oxygen. Not that oxygen is bad, but we just found that even, you know, passive oxygenation, you know, in cardiac arrest situations where you intubate, you know, with a nasal cannula in, actually helps out a lot. Okay, so no, go ahead, just 2 liters of oxygen just to, you know, maintain a saturation is perfectly fine. No one's going to hit you for it. And if any other instructor says otherwise, you can point them my way. I got no problem arguing with an instructor. You're welcome. And as far as colloids, whole blood, we don't have it here. If you go somewhere else in New York or you go anywhere in the Midwest, they do have fresh frozen plasma, FFP, fresh frozen plasma, and whole blood. All right, we don't have the refrigerators for it, not to mention down here, we can spit at a hospital to get you somewhere. But just know that if you do go out of state, especially Midwest, where there's 2 to 3 hours to a hospital, you could be doing TPA, you could be doing stroke protocols, you could be doing whole blood. I think they're teaching suturing and even pericardial centesis out in certain places. So being a medic in other spots in the United States will offer more opportunity. Right? But the whole thing is, and you guys are going to have this lecture in OB, knowing your blood type. Okay? How many, raise your hands so I can look across, how many people here actually know their blood type? That's good. Hang on, keep your hands up so I can scroll across here. Wow, that's pretty good. Wow, good job. You'd be surprised how many people do not know their blood type. Good. All right. I think that's kind of it. There's a lot of repeats. Excellent. Good job, everybody. I'm going to stop recording this.